Okay, thank you. I'm happy to be here. You can see my topic, so let's go to the next slide. So in 1952, Ogden Bruton described A-gamma globulinemia, which was the first primary immunodeficiency, and it was seen in young boys who had recurrent infections because they weren't making any gamma globulin whatsoever. Luckily, they were able to be treated with a gamma globulin replacement. So now we move forward over 40 years later. Discovery of BTK is found to be the cause for A-gamma globulinemia. Two laboratories cloned BTK and sequenced it. And before this discovery, the gene locus was mapped to chromosome XQ22, which is why you only see this syndrome in boys. And it became the first example of mutations in a tyrosine kinase that actually cause a primary immunologic deficiency. And since then, numerous studies have shown how critical BTK is in BCL development and function. I think you all know about CLL, or you probably wouldn't be on the call, but normal cells as well as malignant cells rely on BCR signaling to support their function, enhance proliferation, and enhance survival. So right off the bat, you start to get the idea that inhibiting BCR signaling might be a very positive thing if you have a B-cell malignancy. Both persistent BCR signaling as well as BCL2 upregulation contribute to the increased survival and proliferation that we see of CLL cells. And increased understanding of the importance of BCR signaling in CLL has driven the development of the targeted therapies directed against key survival pathways and proteins, including BTK, which I would say has been the most important one so far. So, and I would agree with what's in the first statement that targeting BTK through BTKIs has transformed CLL management by providing superior efficacy compared with traditional chemoimmunotherapy and less myelosuppression, although as we'll talk about, the BTK inhibitors have their own toxicities. So you can see from the cartoon that why BTK is so important is because it's a messenger once you have B-cell receptor ligation. So when you ligate the BCR, that proliferation and survival signal is translated downstream, and the first step is by the phosphorylation of BTK. You can see from the little cartoon that there are actually other kinases in this pathway, and they've also been targeted. So PI3K, we know that there are PI3K approved drugs in CLL. And sick, there's no therapeutic drug for CLL, but there is a drug approved for ITP. So all of these proteins that are involved in B-cell receptor signaling have been targeted. But again, I think the one that clearly stands out as being the most productive has been BTK. So when you inhibit BTK by inhibiting phosphorylation, you lead to a decrease in B-cell signaling, and this can induce apoptosis or programmed cell death. And also it increases the interactions with the tumor microenvironment, making it less conducive for cancer cell survival and growth. You see in the US and Europe, we have 4 BTKs approved: ibrutinib, acalabrutinib, zanubrutinib, and pirtobrutinib. Zanubrutinib and pirtobrutinib are approved as monotherapy. Well, all of them are, but those two have not yet been approved in combination, whereas as you can see from the slide, both ibrutinib and acalabrutinib have been approved in combination with various other molecules. So this is a patient who was a patient of mine who was actually one of the original participants in a trial with ibrutinib. And this is a typical 11q deletion patient who are mostly men and often middle-aged. And you can see what hair he has there is not very gray. And this was before and after only 4 weeks. So this is just to kind of give you a feel for really how exciting it was to be involved in the early development of ibrutinib and participating in these trials where we saw this dramatic activity. Now, what you also see on the right is that in some cases we saw very significant lymphocytosis. And actually, in some patients who were originally on the phase 1 who had very little adenopathy, they were actually taken off the trial because it was felt that the drug must be accelerating their disease. But when we saw this pattern, especially in patients like mine, where there was dramatic resolution of adenopathy, it became clear that this was not necessarily progression, but something different was going on here. Now, the good news is that most patients can tolerate fairly high lymphocyte counts with CLL without encountering a problem because they're small, very malleable cells. And so usually there are no consequences of this lymphocytosis, and you can see that with time it comes down. And by the way, any of the B cell receptor inhibitors, not just the BTKs, have this same pattern of response. And a lot of research went into this, and it was found that ibrutinib inhibits chemokine-mediated trafficking as well as the retention of CLLs in lymphoid tissues by blocking BTK signaling. So you see here that you inhibit cell migration towards CXCL12 and CXCL13. And so what happens is, as you reduce these cytokines, this is what leads to the release of cells from the lymph nodes and the bone marrow to some extent that go into the blood and lead to this redistribution where you wind up with these transiently high levels of CLL cells that over time die out because they're deprived of the sustenance that they get from being in these niches in the bone marrow and in the blood. This success of ibrutinib established BTK as a key therapeutic target in CLL, but we do have off-target effects that have created the rationale for more selective BTKIs. And one of the simple ways to realize that most of these are off-target effects is that those children with agamma-globulinemia don't develop hypertension or AFib or bleeding, et cetera, like we see as off-target effects. Then we have the first generation BTK was ibrutinib. The second generation are also covalent inhibitors. And now we have the first non-covalent inhibitor, which is pirtobrutinib. The kinase selectivity of the BTKIs are shown here, and you can see that ibrutinib, which sort of looks like it has the dirtiest profile, if you will, there with all of the red spots being off-targeted kinases, tends to have more side effects than the second generation. And then pirtobrutinib, which again is the only non-covalent inhibitor, appears to have the least off-target effects, which makes it a very safe drug. The safety profiles of the BTKIs are closely linked to their kinase binding patterns. And so some of these are class effects, such as cardiotoxicity. And this highlights the importance of really carefully evaluating clinical factors, including pre-existing comorbidities, such as severe cardiovascular disease, when selecting treatment for BTK inhibitors. You can see what's on the screen. Here's just a comparison of some of the off-target effects that we see, and you can see that they're most common with ibrutinib, go down with the second generation covalent inhibitors, and appear to be lowest perhaps with pirtobrutinib. So one issue is the long-term tolerability of covalent BTKIs. Patients with CLL often discontinue treatment. Some of that, of course, is due to progression or refractoriness, but a fair bit of it is to intolerance, such as atrial fibrillation, bleeding, et cetera. And they're a very common reason for discontinuation. And you can see that the bottom of the slide, there is some evidence from real-world studies showing that in some places or in some centers, this can actually be quite high. Okay, another issue that can occur with BTKIs is resistance. Of course, you're having sustained BTK inhibition because all of these drugs that I've mentioned so far are given continuously. So what not surprisingly happens is that the sustained inhibition imposes selective pressure on the CLL cells where deeper pathway suppression may improve disease control, but this prolonged exposure also increases the emergence of resistant clones. And numerous factors can contribute to this. If you look at the boxes at the bottom, you see acquisition of mutations, PLC2 signaling, and then there are other pathways that can lead to resistance. One of the most common is mutations in CYS481. And if you have this, you have problems with binding. And that is true for all of the covalent inhibitors. If you're resistant to one, you're going to be resistant to all of them. But what you can see in the cartoon is that because pirtobrutinib does bind in the ATP binding pocket, but not through binding to CYS481, this drug can be extremely effective in patients who develop resistant to the covalent BTKIs. And in the original Bruin 321 study in refractory patients, only 5.2% of the patients discontinued. There can be acquired resistance to pirtobrutinib with new mutations, and one of the ways to decrease that is, say, combining with another agent and using fixed duration therapy, so you're not using continuous therapy. BTK degraders are also looking very good, and we just heard about them at EHA. So persistent unmet needs in patients with BTKi, treatment discontinuation, right now they're all given continuously, the development of acquired resistance, particularly through mutations, Treatment sequencing, is it, there's now some data for using pirtobrutinib up front, although it doesn't have a label for that. The question might be, would we want to go from a non-covalent to a covalent? Right now, we go from covalent to non-covalent, but all of those questions are arising. Where do the BCL2 inhibitors fit in? And then in patients with really high-risk features, including p53 disruption, although the BTKi were a game changer for these patients compared to chemoimmunotherapy, they still have poorer prognosis disease than people without p53 aberrations. So in summary, BTK inhibition has transformed the treatment landscape in CLL. It's really a cornerstone of targeted therapy. There are differences in the BTKi selectivity, including off-target effects that contribute to safety and tolerability profiles. Despite durable clinical benefit, long-term therapy can be limited by cumulative toxicity, which then requires treatment discontinuation as well as acquired resistance. And the non-covalent BTKIs, and as of now, the only one we do have available is pirtobrutinib, can provide a very effective strategy for overcoming CYS41-mediated resistance. Persistent unmet needs continue to drive the development of next-generation BTK-targeted therapies. We already mentioned the degraders, as well as time-limited combinations.